So good evening, doctors. This expert forum is designed to bring the chest physician experts together to have a consensus on the management of allergic rhinitis and concomitant asthma in adult patients. Today we have Dr. S. Yuvarajan, consultant chest physician, masters in pulmonary medicine, diploma of National Board in Respiratory Diseases, fellowship and European diploma in adult respiratory medicine, Germany, as the speaker and moderator for this expert forum. Dr. Yuvarajan has bagged many awards across the field of respiratory diseases and has been associated with many chest societies and wrote many papers. At present, Dr. Yuvarajan is the head of department in Sri Manakalu Vinayagar Medical College and Hospital at Puducherry. Welcome, Dr. S. Yuvarajan and all the other panel members. Now I hand over the session to Dr. Yuvarajan for an expert discussion. Over to you, sir.
Yeah. Is it visible?
Yes, sir.
Yeah. Thanks for the introduction. First of all, good evening, one and all, particularly to all the panel members. Actually, this is not such a very difficult topic or something different that I'm going to speak. It's not so like that. Basically, it is a common scenario what we see in our day-to-day clinical practice. As a pulmonologist, we may not escape from the patients who are suffering from allergic rhinitis, and it is our duty to see when we are seeing a patient with obstructive airway disease or when you are seeing a patient with asthma. So always, you should always check whether the patient is having symptomatic allergic rhinitis, because that can worsen the picture of bronchial asthma. So in another 45 minutes or 40 minutes session, so we are going to discuss what is the present guidelines to manage allergic rhinitis, and what is the present scenario and what are the available options that we can use for these patients. See, allergic diseases are a major health concern worldwide, not only in India, in all other countries. And it is the most common allergic disorders what we see in day-to-day practice. In our practice, asthma, allergic rhinoconjunctivitis and allergic rhinitis, dermatitis or urticaria, and drug allergy and allergy to specific drugs. There are different drug rash that you may get after using particular drugs, and these are very common in day-to-day general practice. And the global prevalence around 10 to 40% across all the age groups. With an epidemic rise, the prevalence is expected to reach up to 4 billion in 2050. So what is the burden of allergic rhinitis? Over 600 million people worldwide are affected by allergic rhinitis, and about 1 in 6 people suffer from allergic rhinitis, which is another alarming data that was published in area 2008 update. And allergic rhinitis develops before the age of 20 years in 80% of these cases. And in India, allergic rhinitis comprises almost 55% of all allergic disorders that what we face in our clinical practice. 20 to 30% of Indian population suffers from allergic rhinitis, roughly around 38 million. So before going, to the exact, clinical symptomatology and also to the management part, so let's discuss about the basic things. What is the pathogens of these allergic reactions and allergies and all? So as you all know that after exposure to the antigen or allergen, that you get primed to that allergen, and a lot of antibodies, that is IgE antibodies, will be produced in response to the allergen. Basically, when you want to go deep into the pathology, this allergen will be processed by antigen presenting cell, and this allergen, after getting processed from antigen presenting cell, it will be exposed, and then this will stimulate a B cell to produce this IgE antibodies. On first exposure, there won't be sufficient IgE antibodies in the body, so you won't get much of symptoms. But when you get a subsequent exposure, you have a lot of circulating IgE antibodies, and these IgE antibodies will be ready for the next attack. When the allergen comes to this already produced IgE antibodies, this allergen binds to the Fc receptor of IgE antibodies. Once it binds to the Fc receptor of IgE antibodies, this antigen antibody reaction occurs. And as you all know, we have different mediators that can pronounce the allergy. So basically, primary, second mediators are there, and common mediators. What is the culprit in most of the diseases is histamine. So histamine actually irritates the nerve endings and increases the mucus production that is responsible for the early phase allergy. So how it can present, and since it irritates the nasal, mucosa, it can lead to sneezing, itchy, and running nose. That are the common symptoms. And then you see, this Ig antibodies are primed over the mast cell. Once the anti-antibody reaction occurs, this mast cells degranulation occurs. This degranulation leads to the histamine, and the histamine acts on the H1 receptor. This H1 receptors, after acting on the H1 receptor, this is responsible for all these allergic symptoms, particularly the symptoms related to allergic rhinitis. And because of the release of chemotactic factors, the common one is leukotrienes, which acts on the cysteine leukotriene receptors, which will increases the mucus production, which causes vasodilatation, increased vascular permeability. That is responsible for the late phase symptoms, late phase allergy reaction, what we are facing in allergic rhinitis. That leads to nasal congestion, and inflammation that leads to nasal congestion. So there are two phases, like you could see the red. Some of the patients will present with symptoms of eye. They used to tell that some irritating feel in the conjunctiva, redness of the eye, and then they also feel that itching inside the near the inner canthus, and all these things are the common symptom when they present to you along with running nose. So red and itchy, watery eyes, sneezing, congestion, running nose, and you will have a itchy or sore throat and post-nasal brief cough, one of the most common cause of chronic cough what we see in day-to-day practice. This is the cough that we are missing most often, because for this we need to actually trigger the patient's history properly. Otherwise, you may miss this, and unfortunately, the patient has to take a lot of drugs. So these type of patients, those who got a sufficient volume of post-nasal drip, I think you need to target them with good therapy for allergic rhinitis to get rid of this cough. And the classification of allergic rhinitis is based upon area guidelines. So you see that based on the symptom duration and severity, we can do, and based on that, we can classify this into two categories. One is intermittent, other one is persistent. Intermittent category, these patients suffer from symptoms for almost less than 4 days per week, or less than 4 consecutive weeks. If they have symptoms less than 4 days per week for less than 4 consecutive weeks, we can classify them as intermittent type of allergic rhinitis. So what is persistent type of allergic rhinitis? In the persistent category, the symptoms will be there for more than 4 days per week or more than 4 weeks. So any of this is there, then you can classify them as a persistent variety of allergic rhinitis. So based on the severity, how it affects the quality of life in the patients. So whether it affects the sleep or not, whether it affects your day-to-day activities or not. So all these things you need to ask when you are seeing a patient with allergic rhinitis. So in a mild category, the patient will have normal sleep, no impairment of daily activities or sports or leisure activities, normal work and school. There won't be any school loss or any, you won't get any disturbance at school, and no bothersome symptoms due to allergic rhinitis. Moderate to severe category, abnormal sleep and impairment of daily activities, sports and leisure, and problems at work and school, bothersome symptoms are there. So these, if they present with these symptoms, we can classify them as moderate to severe category. The clinical profiles, the phenotypic profiles are like what we see actually in our patients are. Some of the patients will present with itchy nose. Some of the patient will present with sneezing, only sneezing, or some group of patients present with sneezing with a little bit watery discharge. Some patient will have a watery discharge, like they used to tell that continuous, nose discharge, nasal discharge, and then they feel like like a water pump is attached to the nose. Like this is what we used to get from the patient's history. And itchy nose and eyes. These are the different category patients that what we see in our clinic. And some group of patients, they always present with congestive symptoms. They will have a nasal blockage. They'll have a thick mucus, and that lead to post-nasal drip. And sometimes allergic rhinitis also presents with minimal nasal discharge, minimal itching, and then more of post-nasal drip cough. So you need to catch these phenotypes, and then you need to treat them early to avoid all the symptoms and to avoid all the irritating complications. So the clinical profile of patient with allergic rhinitis in India. You see in India, based on this data, that was published in Journal of Clinical Diagnosis in 2014, you could see almost 48.5% of people presented with nasal obstruction, 33% with running nose, 24% with sneezing, and 20% with nasal itching. So in India, if you see the symptom distribution, almost 64% have nasal blockage and 36% have sneezing and running nose as one of the primary symptoms. When you see the severity as per the area guidelines, moderate to severe persistent AR were the most common type seen in Indian scenario, roughly around 1/3 of patients what they studied. So how it affects your lifestyle. Up to 57% of the people with allergic rhinitis have trouble sleeping at night, which leads to daytime sleepiness and tiredness. Each year, almost 3.5 million workdays are lost due to allergic rhinitis. On any given day, about 10,000 children are absent from school because of allergic rhinitis. Allergic rhinitis increases the medication cost to the patients by twofold. So what all it can lead to if you are not identifying early and if you are not catching the comorbidities early, what all it can lead to? It can lead to it. It is not necessarily it can lead to asthma. Basically, it is actually one area, one disease concept. So if you have allergic rhinitis, definitely this patient, you need to look for airway disease, or the patient have airway disease, you need to look for a nasal symptoms or allergic rhinitis. And also you need to see the patient have sinusitis because of the persistent rhinorrhea and then nasal congestion. You will have a terminate hypertrophy. You have poor aeration to the sinus and then poor blockage of the sinus tracts, and that lead to sinusitis, which can get complicated with acute and chronic sinusitis. And nasal polyps, very, very bad complication that I used to see in my clinical practice. Bilateral nasal polyps, it's very difficult to treat, and these patients are will be sent to polypectomy and surgery. And one of the bitter fact is that, like, the polyps definitely recurrence will be there, and you need to advise the patient after polypectomy they should follow the protocol properly to avoid the hanging mucosa, to avoid edema of the mucosa because of allergic rhinitis, and that's why the protocol has to be followed meticulously. And because of nasal blockage, you will have inflamed eustachian tube, and there is a high risk of infection of middle ear, and that leads to otitis media and repeated upper respiratory tract infections. And most of the times in allergic rhinitis, these patients who have a persistent nasal discharge, these patients, if they are kids, most of the times what I see is that these patients also have pharyngotonsillitis. So rhinitis, pharyngotonsillitis, persistent nasal, post-nasal drip discharge, and usually that tonsils regress by 8 years. These group of patients, those who have a persistent discharge and persistent post-nasal drip, they have prolonged hypertrophy of tonsils, prolonged their presence with tonsillitis, pharyngotonsillitis, repeated sore throat, and all these things when you follow this case. So what about AR and asthma? How far it is correlated? So AR is a risk factor for asthma, and uncontrolled moderate to severe AR affects the asthma control. Up to 40% of patients with allergic rhinitis have asthma. A survey by All India Coordinated Project on Aeroallergens and Human Health, New Delhi, showed that among population suffers from allergic rhinitis, 15% develop asthma. A large number of cross-sectional studies have demonstrated that nasal symptoms have reported among 28 to 78% of the patient's asthma. So that's why we need to ask clear history that whether the patient also have allergic rhinitis when you are seeing an asthma patient. Because if you are not treating allergic rhinitis, the control may not be appropriate with your available drugs. So as per the cross-sectional observation study, which was conducted to identify the demographic clinical profile of patients with AR in India. So this is the data. So you could see almost 48 patients with allergic rhinitis were screened, and 62 patients were finally diagnosed with allergic rhinitis were included in the study. So out of that, you could see the comorbid conditions of allergic rhinitis. 50% were bronchial asthma, 39% had sinusitis, 22% had atopic dermatitis, and 14% have concomitant allergic conjunctivitis also. So nearly half of the study subjects in the study with AR also had asthma. So this is part of discussion to avoid, boresome lecture. So just I want all the panel members to give their feedback and opinion. So in the last 5 years, what is the trend in the epidemiology of allergic rhinitis observed by you? So anyone from the panel?
Actually, after COVID, everyone is using masks. The incidence of prevalence of allergic rhinitis has reduced.
Okay, sir. Okay, sir. Okay. Anyone?
Now in the last 6 months, we can notice most of the people have come out of COVID, and they
Yes.
started going to school and
Yes.
other things, and
True.
routine works. I think it is slowly on the increasing trend nowadays.
Yes. Yes. True.
Yeah, I second that opinion. After this reopening of school, past 4 months, we see an increase of allergic rhinitis not only in children, also their associated family members also
Yes.
probably
Yes. Yes,
acquired
Dr. Harish.
from
Yes.
school.
Yeah, that is definitely true. Yes, actually, mask actually one other thing like potential trigger exposure to allergens and all these things. I think it might have reduced. I could also see some patients who are having symptoms related to allergic rhinitis for many years. Actually, during the time of COVID, they have not come, and now they told that now they are coming for almost like for the past 1 or 2 months. They were telling that previously they were very good when they were staying in home with mask. At the time, they were not that much symptomatic. That's true.
So I think we should decipher that the cause or etiology of allergic rhinitis is school.
Yeah.
Or probably I think the trigger factor is the viral, usually from either
Yes.
office or
Yeah,
school.
yeah.
Yeah. So I think
Yeah, the trigger for allergy is not only allergen, as you are telling, even a transient viral infections also. Even URT also can trigger your
Correct.
all the symptoms.
And
Yeah.
also, on the contrary, we see a lot of patients with pre-existing allergy after COVID. Their
Yes.
allergies have gone up.
Yes, yes. Actually, two group we are seeing. Actually, one group actually
vaccinated people
already they
also
have
there.
a family history of. Yeah.
So after getting a COVID vaccine, some people is getting the no more number of patients seen after getting vaccine.
Yeah, they were telling that after getting vaccinated only, I'm having these symptoms, sir. My father and mother were having, I was not having. My age was around 40. They were telling like this. After getting vaccinated only, I'm having running nose, sneezing, and some amount of
Yes, sir, yes,
VC
sir.
symptoms. This was the usual picture that what
Yes.
we are seeing. That's okay. What is the prevalence of allergic rhinitis in your clinical practice out of everyone? Like I'm asking to everyone, like how far you are treating? Like I am seeing AR myself only. I'm not. I'm referring some group of patients of AR to ENT, and other patients I'm seeing. What about yourself, sir? Yes.
So usually we don't refer all the cases of AR to ENT surgeon. As you already
Yeah.
pointed out that any patient who has nasal polyposis or
Yeah.
severe obstructive symptoms who may need
Yes.
FS, that is functional
Yeah.
external of the sinus surgery, we refer to an ENT surgeon.
Yes, sir. Yeah.
Otherwise, I think we can manage with inhaled nasal steroids with an antihistamine if at all it is needed.
So most of the times, what they are doing after the face is okay, but most of the times for simple allergic rhinitis also they have a DNS that not that much symptomatic. I could see there are many DNS surgeries have done, and after that they were telling that 3 months they are not symptomatic, and after that they are having symptoms. So finally they are landing.
I don't recommend patients to go to surgeon and do a DNS correction until
Yes.
otherwise it is a huge S-shaped deviation.
Yes,
So mild form of
yes.
you can only treat it. That is not a
Yeah.
problem.
Yeah, true, sir.
And, these patients with chronic allergic rhinosinusitis, if they have sinusitis, we'll have to see whether it's a fungal or not. Definitely, if it's a fungal, we'll have to warrant an ENT consult.
Yes.
And also the osteometal units, whether it's blocked or open.
Yeah.
That also we will have to see.
Yeah, the two group actually, those patients who got a completely blocked nose with a polyp, those patients who got a fluid level, chronic thickening, and those patients, as Dr. Harish was telling, that if you think that it is the etiology is fungal ball or anything like that, if you see the sinus chronic thickening, some amount of bone reaction, all these things are there. Definitely, you have to do. And there are some cases that you could see that a complete, S cross shaped, the cross shaped DNS, completely, deformed septum. And also the patients with complete block of that meatal opening. So these group of patients at least one time
Definitely, they will have to go through this sinus surgery at least one time. At least it might not be a curative for allergic rhinitis.
Yeah.
At least it will lessen the frequency of allergic rhinitis and secondary post-nasal drip and asthma.
True, Dr. Yes. So the next, what are the common symptoms? You could see I have explained all the phenotypes that what I have seen. So what do you think that are you agreeing with the data, whatever that was presented just before a few slides before, like nasal blockage is a common symptom, or do you think that running nose or sneezing? What do you feel as per
Majority
your
of the patient, what we see, would present with only nasal discharge and nasal congestion. So nasal block, I feel it is little less when compared to nasal congestion rhinorrhea.
Yes, sir. Yes. And during your routine practice, how many percentage of patient do you have AR with asthma?
So maybe
or
around
the patient is coming and telling to you that they are having allergic rhinitis, or they have asthma, they are telling, or not?
No, see, actually, I see around the 20% of my outpatient patients with allergic rhinitis. I always tell them, if you don't take medicines, whether they fall into mild, moderate, or severe category,
yeah,
or whether they fall into seasonal or perennial condition, I tell them, if you do not take medication for allergic rhinitis, you will land up in allergic sinusitis, otitis
yes,
media,
yeah,
and I also tell them nasobronchial crosstalk,
yes,
which
yes,
means they can land up in asthma. When you
yes.
see an asthma patient also, when you carefully elicit the history,
Hmm.
they would have been having allergic rhinitis untreated.
Yeah.
So this nasobronchial crosstalk will be there. So they develop asthma. Actually, we educate them. I spend a lot of time.
Yeah.
I tell them, you take the medicines daily in the night or in the morning, half an hour
Yeah.
before food, and this is a wonder molecule. So it gives good relief, actually.
Yeah, that's what actually the nasobronchial crosstalk and sinobronchial allergy. There are some sinobronchial reflex. Some studies they reflect sinobronchial reflex. So basically, these patients have a chronic cough and irritating throat and all. When you see, actually, the trigger will be there in the nose and sinus tract. So, as you rightly pointed out, all the things that whatever discussed. Okay, so we move on to the discussion. What are the present modalities that are available for diagnosis, and what are the investigation we should do for a patient with allergic rhinitis? After taking a proper history, you should question regarding the person's family history, environmental triggers, household triggers, and all these things you should ask. And physical examination, you have to examine the nose, look for DNS, look for polyps, look for hypertrophy in this turbinates, and all these things you should see. And allergic testing, whether it is really needed or not. Actually, some patient I used to do IG level and skin prick test. I am not practicing, but skin prick test and the blood test that we can perform for some patients. All patients with persistent allergic rhinitis, asthma should be routinely investigated by history. Asthma include clinical signs of dyspnea, airflow limitation, and hyperventilation. All these things has to be, if needed, definitely asthma should be diagnosed with spirometry. You should actually differentiate because usually the same running nose, irritation in the nose will be there in common cold also, in flu. How to differentiate that? The common cold usually presents for less than a week. Allergic rhinitis usually more than 2 weeks. Nasal discharge will be mucopurulent. Of course, sometimes you may have a mucoid discharge and serous discharge in common cold also. Here, you won't get mucopurulent discharge in allergic rhinitis. Facial pain and pressure, of course, definitely you will get in common cold, but in allergic rhinitis, most of the cases you won't get. Post-nasal discharge with cough, yes, you will get. And allergic rhinitis, you may not get, but some chronic patients, you may get this post-nasal drip and cough. Olfactory disturbance, yes, you will get in common cold. And allergic rhinitis, in case of chronic allergic rhinosinusitis, I could see the persistent nasal blockage also disturbs the patient's smell. Fever, you will get fever in case of common cold, whereas fever, you may get this fever in not necessarily in all the case of allergic rhinitis, except in drug allergy, exposure to aspirin, all these things. You may have a transient episode of congestion of eyes, allergic rhinoconjunctivitis symptoms will be there. So in that case, you may have a mild fever. Otherwise, you should not get a fever in patient with allergic rhinitis. Unless, yes, you will get some amount of myalgia and body pain will be there. And allergic rhinitis, you may not get this symptom. Sore throat will be there in common cold, whereas in allergic rhinitis, you should not get a sore throat.
Yes.
So what is your this is for general panel, like general discussion for the panel. What is your approach towards the diagnosis of AR in your patients? So only with the clinical history, and you grade the patient as per area, or you will do all this IG levels, absolute eosinophil count, all these things you'll do.
I usually go with the guidelines as you had told you, Raj. So that is very important.
Yes,
so
sir.
to quantitate with the symptomatology, we will go with the guidelines. The majority
Yes,
of the patients do moderate or intermediate type of allergic rhinitis.
Yes,
Any
sir.
patient who have symptoms like nasal polyposis and other things, we go ahead with the CT of the paranasal sinuses, or
Yes.
we proceed to go with nasal endoscopy by
Yes.
ENT surgeon. And according to that, we will treat. That is what I usually practice.
Yeah. Any other panel member want to discuss on this?
Yes, sir. Yuvraj, these patients who have
Yes.
chronic persistent symptoms definitely needs further evaluation, like
Yes.
going on to narrowing down the cause with
Yeah.
IgE, eosinophils, evaluation of the sinus, additional
Yeah.
comorbidities. And if uncontrolled, still having persistent allergic rhinitis, these probably next step would go to skin prick test, SPT. So in that
Yeah.
case, definitely we will have to do that. But in mild case, less than not, if it's not persistent, probably we need not investigate further. But
Okay.
even in mild case, if they are suboptimally responding, probably that also warrants further evaluation.
Yeah. Okay. So what about skin prick test? As per you all, what do you feel about skin prick test? Where you
I
place
never
skin prick test per year?
Fine.
Frankly, I'm asking. Frankly, see, I'm not doing it. That's what. Because see, unless
not
otherwise
doing
you go for, you go for, we have facility, but I don't want to harm the patient too much. Unless otherwise you don't have, you are not able to control the, the symptoms and all this thing. You want to focus on some immunotherapy and all. You can go ahead. Otherwise, I don't feel. What about others' opinion? Like I usually do, if you want to have allergy, we are doing allergy panel. It is almost equally good, but only thing it is costly. That's it. So if I want to do, I will send allergy panel, particularly for, we have comprehensive allergy panel test also is there. Particular lab I used to send, and that is doing well and good. Previously, I was sending for skin prick test, but for AR, I won't send. That's what my
The
opinion.
allergic panel which you are talking, it's IgE mediated allergic panel by CLIA.
Yeah, yes.
That's expensive, isn't it?
Yes, it's expensive.
than
That's what
18,000
that is for selected patient. What I'm telling, some patient will have persistent urticaria. They might have seen a lot of dermatologists. Some patient along with urticaria have asthma along with the allergic rhinitis.
Yes.
So these group of patients for getting immunotherapy done and for getting some amount of avoidance and all these things. To get a clear picture, so I used to order. Otherwise, I won't do skin prick test.
Yeah. Now, skin prick test we are doing at Kaveri Hospital where I practice, and also my clinic specifically. If the patient, I'm sure, has been regularly following up with me, then I do select the patients with severe allergic rhinitis who are not responding. This will compromise 5 to 10% of the patients.
Okay. So what about others, like we've been doing skin prick test? Because those patients who are having persistent symptoms after all your therapies, we need to find out the potential trigger. That is the duty of us actually. For that, definitely we need to pick up the allergen. So then that case, definitely these type of tests, RAST and this skin prick test and all these things might be helpful, I feel. Okay, so moving on to the management part of allergic rhinitis. The first and foremost thing is to avoid allergy exposure. Avoid the exposure of allergen to prevent allergic reaction, but it is not possible always because it is very difficult to avoid, allergen exposure. And preferably inhaled allergen exposure, like you can ask them to wear mask in the dusty area and environment. Use of allergy shots in the body to make the body familiar to allergen. So it is like immunotherapy, what we were discussing. It is not very cost effective and it can lead to immediate local systemic. There are two forms of immunotherapy. We have sublingual and injectable form. We can use. The problem with immunotherapy is that these group of patients like allergic rhinitis patients and urticaria patients, they may not be allergic to a single agent. The problem is that they may be allergic to multiple agents. So the problem, what problem we face is that we have to give this therapies for all the thing, and you have to like a cocktail mixture we have to do, and the therapy will be long duration. So most of the patients who face this type of therapy, after leaving that, there are some patients who just come up with recurrent symptoms. So I think this immunotherapy should be restricted to those patients who are not responding to a regular therapy. Those patients who are having this reaction to a few allergens, we can do that. But if you see the patient with severe urticaria and allergic rhinitis, not responding to a regular therapy, if you do a skin prick test and if you do that, some patients, if you get that, if you can see that they will be having a reaction to multiple allergens. So in that group of patients, it's very difficult. Use of anti-allergic medication to suppress the immune response. This is a pharmacotherapy. That's what we are going to discuss now. So if the patient presents to you with vasoconstrictive symptoms like to block nose and all, you can use a topical nasal decongestant. Pseudoephedrine, phenylephrine, oxymetazoline are available. And intranasal steroid, one of the very important therapy that we are using for allergic rhinitis. Those patients present with moderate to severe symptoms, definitely intranasal steroids plays a major role in all the patient with allergic rhinitis. It is fluticasone, propionate, furoate, mometasone, everything is available. Antihistamines, common oral drugs that we give for allergic rhinitis, they block the action of histamine and control sneezing, itching, and rhinorrhea. Fexofenadine, levocetirizine, bilastine, you can give either first or second generation. Basically, we need to prefer second generation only because to avoid all the symptoms, anticholinergic symptoms, and also sedation. So anti-leukotriene, that's montelukast, one of the most common and sometimes one of the most misused drug. So they inhibit the effect of leukotrienes, that is particularly late phase response. That's what initially I discussed, which are the underlying cause of inflammation, allergic rhinitis. So what area is telling? So in area guidelines, the diagnosis, after you are diagnosing a patient with allergic rhinitis, always you try to check the patient whether the patient is having asthma or not. And then based on the symptoms, you classify them as the intermittent and persistent symptoms. And then based on the severity, mild to moderate, you can classify. All the patients with mild symptoms and intermittent symptoms. So mild severity with intermittent symptoms, you can just start with the oral medication, oral antihistamines, preferably non-sedative antihistamines you can give. H1 blocker, intranasal H1 blocker, or decongestant you can give along with LTRA. So leukotriene receptor antagonist you can prefer. So if the patient is having intermittent symptoms, but severity of moderate to severe category, so once again, oral drugs plays a major role. Oral H1 blocker or intranasal H1 blocker or a decongestant or intranasal corticosteroid LTRA. So here you are using intranasal corticosteroid in moderate to severe category. In persistent symptoms, even in mild severity also, you can use the same thing. You add one oral antihistamine along with the intranasal corticosteroid. In case of persistent rhinitis, like review the patient after 14 days to 28 days. So maybe after, usually that is the usual way that I used to follow up the patient with allergic rhinitis. After 15 days to 1 month, I used to ask the patient to come back. If failure, either you step up the therapy. If improved, continue for 1 month. And if the patient have persistent symptoms and have severity or moderate to severe category, in the preferred order, you can use intranasal corticosteroids and you can use H1 blocker or LTRA. Once again, review the patient after 2 to 4 weeks. If the patient improved, then definitely step down the therapy and continue the treatment for more than 1 month. If that is a failure, you can review the diagnosis, you can review the complaints, you need to rule out the infectious cause and other causes. If the patient have, rhinorrhea more and having more symptoms, you can add or increase intranasal corticosteroids. And we can also, for rhinorrhea, we can also add ipratropium, but unfortunately, we don't have ipratropium sprays available in the market. So for this, I'm doing for this. Actually, there are some patients. If you have a persistent rhinorrhea, in India, actually we don't have this ipratropium sprays. And for nasal blockage, you can add a decongestant or a oral corticosteroid for short term. But I don't prefer this oral corticosteroid. And failure, you can refer to a specialist. So this is based on the recommendation. Some patients with AR who have concomitant asthma, especially excess-induced aspirin exacerbated disease, might benefit from a LTRA more than from an antihistamine. So you need a synergistic combination to address on all these symptoms. So corticosteroids have very good effect on sneezing, reduces itching, rhinorrhea, congestion, and eye symptoms will be much improved with the use of corticosteroids. After using antihistamine, similarly, it checks on sneezing, itching, rhinorrhea, and antihistamine definitely not much effective on congestion, and also it gives good relief for eye symptoms. Anti-leukotrienes, mainly for congestion, nasal congestion, anti-leukotriene plays a major role for other things also like sneezing, itching, rhinorrhea, but it is somewhat less effective than corticosteroids. Anticholinergics, already we discussed, it is much effective for running nose, rhinorrhea. Decongestants, definitely for congestion, it will be definitely helpful. So enhance therapeutic effectiveness by combining an antihistamine with an anti-leukotriene that will alleviate both early as well as late symptom of allergic rhinitis. It is another synergistic combination we are using to counteract this allergic rhinitis. Okay, the treatment recommendations of mild case of intermittent or persistent allergic rhinitis. What do you use? Oral antihistamine, combination of oral antihistamine with montelukast, intranasal steroid, or any other preferred choice.
So we would request Dr. Kumaran, Dr. Tirupati to also contribute. We also have Dr. Palini Appan.
Actually, I use this oral antihistamine with montelukast.
Okay.
Hello.
Okay. Yes, sir. Yeah. Go ahead, sir.
Am I audible?
Yeah. Audible. Yes. Go ahead, please.
Yes, sir. In fact, sir, what I do is if they don't get controlled with Bilastine and montelukast, because most of them fall into mild to moderate category.
Yeah.
Only if they land up in a severe condition or they land up in a perennial, which is throughout the year they are suffering from the symptoms.
Yeah.
Then you combine antihistamine with the montelukast and inhaled corticosteroids. But as you rightly said, the nasal itching, rhinorrhea symptoms, they say as soon as they get up in the morning, they sneeze 20 to 30 times actually.
Yes. Yeah.
So generally I start with antihistamine with montelukast. Then if they land up in a perennial or a severe category, as you rightly said, the clinical variant symptoms affecting their sleep and then day-to-day activities, then only I go for an inhaled corticosteroids.
Sir, most of the patients are coming like that only, sir. Like for simple allergy, they were telling that why these many days you are not coming, sir. Simple rhinorrhea, why to see the doctor like that? They are telling like that.
No, but I tell them, I educate them. If I tell them, you
Yes,
take
sir,
Bilastine with the montelukast, this drug is going to be effective for 24 to 26 hours because the duration of action is, so you have to take it daily. And if you take it daily, definitely you will have symptoms. And they understand, I educate them. They take it regularly and get relieved of the symptoms. It is non-sedating. And one man uses, it should be taken on an empty stomach for better efficacy. And it also does a wonderful
that we are
job.
going to discuss. That we are going to discuss, sir. So,
yes, sir.
So how long you will ask the patient to take for continuously for, how many days you will ask your patient?
6 weeks.
Generally 3 months, sir. If there's a mild category, seasonal, 3 months, then review. But I ask them to meet me every month and based on the symptom, we decide the duration of treatment.
Yeah.
Thank you, sir.
Yeah. So what is your preferred drug in the management of moderate to severe syndrome, intermittent AR and persistent AR? So this is all we discussed. I will move on to the next slide. So out of different antihistamine, which would be ideal. So we have first generation, old generation antihistamine that will cause sedation. Second generation, that is new generation, are safer, potent, and have a quick onset of action. So we have Bilastine, which is a novel, multifaceted second generation antihistamine with the highest number of desired features for ideal antihistamine as per the area guidelines. So you could see the comparative data with the regular antihistamine what we are using, cetirizine, levocetirizine, and desloratadine. So metabolism not metabolized.
So you are on mute.
Sir, you are on mute, sir. So kindly unmute, sir.
Yeah. Now can you hear me?
Yes, sir.
Yes,
You are
sir, but
audible.
the slides are not visible, sir.
Slide is not visible.
No, sir.
Okay. 1 second. I'll add the slide. Now you are seeing?
Yes.
Yes, sir.
Check. It's not going for a. It's not going for a slideshow. Is it okay now?
Yes, sir, it is fine, but it is not on slideshow.
Yeah, actually, it's not. I could not change this to slideshow. Actually, it's not resume slideshow. Okay, now you are seeing it.
Yes, sir.
Okay, 1 second. Okay. So once again, I'm highlighting the features. You could see the receptor selectivity. You could see out of all the antihistamine, belastin have high H1 receptor selectivity. Affinity almost 3 times better than cetirizine and 6 times better than fexofenadine. No affinity to 30 other receptors, so there's no chance of side effects. Offers potency superior to that of fexofenadine, what we are using. And regarding the onset of action, it acts as early as possible within 45 minutes. And when compared to cetirizine steroid, it's very good. So belastin 20 milligrams showed a faster onset of action within 45 minutes when compared to fexofenadine in allergic rhinitis. And regarding duration of action, it acts for at least 26 hours. It has 100-fold higher residence time compared to first generation antihistamines. And longer residence time. One second. Can you see?
Yes, sir.
There's some problem with network connection. That's once again. Yeah, it has a longer residence time of 73 minutes versus 60 minutes when compared to fexofenadine diphenhydramine. So belastin shows almost 60 to 70% of H1 receptor antagonism 24 hours post-dose, while the plasma concentration decreased below the pharmacological active concentration. So when you see the data, it is almost, like significantly more effective than fexofenadine between 22 to 26 hours. So when you see this data, so you could see the belastin, the mean global symptoms, how far it is effective when compared to fexofenadine. So based on this data from Japan, in a study from 126 patients, they compared, they compared all the drugs belastin with fexofenadine along with the placebo. So what they found is that the transnasal symptom score at TNS is a transnasal symptom score. What they do for allergic rhinitis, nothing. It is actually a questionnaire. It's a simple questionnaire with all the points for rhinitis, rhinorrhea, and itching, sneezing, and also nasal blockage. So these are the 3 common cardinal symptoms in that questionnaire. So based on that, they will mark the transnasal symptom score. So you could see the mean transnasal symptom score at 0 to 3 hours and at 20 to 26 hours after first dose. You could see the belastin perform much better. The more significant reduction of sum of TNS or sneezing score on day 1 than fexofenadine twice daily. So relatively greater inhibitory effect than that of fexofenadine. Belastin 20 mg demonstrated efficacy, rapid onset of action within 45 minutes, and longer duration of action in the subjects. And based on this data, it is very effective in reducing all the nasal symptoms. So the change in TNS score of belastin was significantly greater than fexofenadine on day 1. Constant decrease in daily DNS from the baseline from day 1 to day 13. And compared to fexofenadine, it is much better, which showed a gradual decrease until day 3, then suggesting a rapid onset of action. An anti-inflammatory effect beyond this antihistaminic effect. So with belastin, the significant effect on nasal obstruction, which is one of the bothersome symptoms for AR in some patients. A significant reduction in nasal obstruction also noticed after using belastin for the first day when compared to other antihistamine. And offers lasting protection in relation to eye symptoms. Sorry, it also checks on your eye symptoms. Regarding the safety, one of the most important thing that what you should note, because most of our patients are concomitant, CAD patient having ischemic heart disease, diabetes mellitus, and all these things. So all these things we need to take care. It should not be so risky drug. So when you see belastin, the risk of sedation is very less, and then lowest reported rates of CNS H1 receptor occupancy and high affinity for PGP efflux pump restricts transit across the blood-brain barrier. So it is considered as a non-brain penetrating antihistamine, like what you see in fexofenadine and all these things. So, and regarding drug interaction, no significant drug interaction with COP enzyme system, and 95% of oral belastin dose is excreted unchanged. Minimal sedation or cognitive impairment or psychomotor impairment, and it is one of the optimal choice for which would not affect your driving performance, and no impact on the flying performance. This is based on the data published by Demont et al. And Conan S. et al. Excellent safety profile. So there is no weight gain. There is no allergic, anticholinergic side effects as you face in first generation antihistamine like dry mouth, urine retention, and constipation. And cardiac safe, the only commercially available antihistamine that has been tested with stringent policies. So this belastin is the only drug that has been tested with stringent policies. Safe at therapeutic and super therapeutic doses. No clinically significant impact on QTC interval and T-wave morphology. No alteration of cardiac safety and co-administration with COP50 and PGP inhibitors. Even in elderly patients, based on this data, you could see the incidence of side effect like dry mouth and all is far very less when compared to other antihistamines. Even for long-term treatment also, you can prefer this agent. As you see that there are no adverse reactions reported in this data at 12-week, 52-week treatment. So you could see, you could not see much of changes, no abnormality in ECG, no change on the variables, but you could also see the clinical significance like improvement in TNS score, TOS score, and TSS from day 1 to 3, and it is maintained up to 52 weeks. And most important thing, quality of life also improved after using this. So once again, I am just recapitulating the things. Belastin is one of the very good drug, which has a rapid onset of action, long duration of action, no sedation, cardiac safety is good, no doses needed in case of renal disease and all, and effective and safe in elderly patients, and no drug-to-drug interaction. And next is montelukast. So basically, montelukast is a very old drug that what we are using. So only LTRA that is being used in allergic rhinitis, a twofold greater affinity than natural ligand, quickly absorbed, excreted exclusively in bile, no significant interactions, minimal distribution across the blood-brain barrier. So highly selective liquid receptor antagonist blocks the liquid receptors, which is very effective for controlling the late phase allergy symptoms. So you could see the montelukast, how it improves the daytime and nighttime symptoms, particularly when you see the congestion, rhinorrhea, pruritus and all. It is much improved with montelukast. And montelukast, most thoroughly tested and prescribed drug. It provides relief of symptoms for 24 hours, effectively decreases nasal inflammation, remits nasal congestion, reduces eosinophilic airway inflammation, also improves the quality of life. Okay. You could see already I described all these things. So allergic early and late response. This will be contracted by your belastin. This will be contracted by your montelukast. Okay. The basic dosage what we are using regularly, but one thing that you should not forget is that it has to be taken with in the empty stomach. That is very important for belastin. I think that's it from my end, because I don't want to waste your time. Yeah.
Thank you so much, sir. Sir, I would request Dr. Tirupati and especially Dr. Muhammad Arif also to contribute.
Hello, good evening, everyone. Are you hearing me?
Yeah. Good evening, sir.
Good evening. Regarding the molecule, there is absolutely no doubt the number of companies coming out with this combination itself is a testimony to the success of the molecule. No doubt about that. But still, everybody will agree that the potency-wise, definitely the levocetirizine is much advantageous, powerful for patients who are having severe symptoms. For all other patients, belastin molecule will be definitely very good, especially in the context of least sedation offered by the drug. At the same time, it is very effective.
Yeah, I will also accept that fact, sir. So there are many patients with severe form of allergic rhinitis, even though we speak theory a lot, and practically when you see, definitely there is some doubt in that actually. For severe symptoms, definitely there is some doubt.
And always there is the intranasal corticosteroid, which is the king of treatment of all the symptoms of allergic rhinitis. But for all other patients, this is a wonderful molecule.
Yeah.
Yuvraj, other question from my side. Have you used this drug in pregnant and lactating women?
No, sir. No,
far
sir.
so.
No, sir. Sir,
Okay.
even in, so for second and third trimester, I used to use Montelukast with levocetirizine. But
Yeah,
first
good.
trimester, definitely not. But that too only selected patients, sir.
No,
For
I'm asking
AR
not
in,
about Montelukast.
yes, yes,
I'm
sir.
asking about plain Bilastine.
No,
Plain
no, sir. I
Bilastine.
have not used. I have not used
You are not
because
used.
we are not very sure of the safety of molecule in pregnancy.
Definitely.
So I think it's not better not to use, sir, in pregnancy. In
Fine.
pregnancy also, sir, steroids, the safer steroid is what I'm using is budesonide intranasal steroid. Because we have a good safety data for budesonide, both airway and also for nose. We have some few companies with budesonide nasal spray. I'm using that only, sir.
Oh, good. That's good.
Yes, sir.
And the same thing about acylastine in pregnancy. Intranasal.
See, acylastine also, like when you see the data, it is not considered to be very safe. If the if the benefits outweigh the risk, the patient is having very severe rhinorrhea, not able to control their symptoms. That group of patients, acylastine for other patients we are using, but in pregnancy actually we need to see and use. If you want, you can use in second or third trimester.
Claire, one question. I mean, how long we can use this Montelukast with antihistamine combination? I see patients taking for years together.
Yes, sir. Yes, true.
Without the prescription, if we give one prescription, they'll be taking for years together.
Yes, sir. Sir, this is a right question because as we are discussing a topic, it's a never-ending topic, allergic rhinitis. Even though if you speak a lot, if you read a lot of guidelines, a lot of literature also, patient will come back once again. This is a fact actually. Sir, I feel that all the oral drugs has to be restricted for short duration, even though it is safe. It is unnecessarily you should not take some drug. So actually, sir, Montelukast received a black box warning from FDA. You could see. You can also see after this webinar is over. Montelukast received a black box warning for its neuropsychiatric symptoms, especially in children, when used for some duration. Nighttime symptoms, they will have a teeth grinding and all these things will be there. So I don't think any drug will be safe if you take for long duration unnecessarily. For that sake, it's always better to use topical drugs. I feel you can give a short burst, sir, not like years together. I think it's not better.
Yes, I agree with Dr. Yuvraj in this, and adding to the Montelukast black box warning, they've told that it increases the neuropsychiatric manifestations in these patients, especially the suicidal tendencies. So
yes.
We'll have to be very careful while giving long-term Montelukast in patients already having neuropsychiatric disturbances.
Yes, especially about these patients are very difficult. Actually, more than allergic rhinitis, we are seeing some patients with urticaria. Some of my patients with urticaria allergic rhinitis, they used to take some antihistamine with the dermatologist, and some we may be prescribing some antihistamine from our side. So the problem is that the patients with urticaria, they will be taking antihistamine for long duration. They can't survive. Like they used to tell that without taking antihistamine, they can't escape from their symptoms. Maybe I could see like a lot of practitioners. I think you might have faced the same thing. Urticaria patients, at least one antihistamine they will take for a day. Persistent chronic urticaria. I think we can. Can we finish this?
Yeah, absolutely, sir. Thank you so much, Dr. Yuvarajan and all the other panel members. It was an informative session, of course, and a wonderful discussion wherein everyone was enlightened in terms of the treatment or management of allergic rhinitis in adult patients. I would like to thank each and everyone for spending their time on this conversation. Thank you so much, sir.
Yeah, thank you so much. Thank you all panelists. All are my friends, seniors, and all. Gopinath sir and all. Very happy to see you. Yes, sir. Sir.
So nice to see you.
Yes, sir. Thanks, sir. Harish and all.
Thanks a lot. Thank you.
Thanks.
Thanks. Tribhubai sir and Mohammed. Bye. Thanks.